during therapeutic irradiation. In this presentation, I will briefly introduce prostate cancer, its radiotherapy, and the objective of my study. Then I will present three of the studies which I performed during my PhD thesis work. First study was about interfractional prostate motion comparison using different setup techniques. Second study was about bladder and rectal filling effect on the prostate motion. And in the third study, dosimetric comparison of two planning target volume margin concepts will be done. And in the end, I will give a brief summary and outlook of my work. Prostate cancer is an abnormal growth of cells in prostate with the potential to invade other tissues. It's most common cancer among men, 15% of all male cancers. And it is the fifth leading cause of cancer-related deaths among men worldwide, as per Globocan. Treatment modalities with curative intention include surgery and radiotherapy. It is documented that 50% of prostate patients can be benefited from radiotherapy. The center where I worked during my PhD was having a photon therapy facility with Siemens linear accelerators in which both 2D and 3D image guidance options were available. For 2D image, exact X-ray imaging, stereoscopic images were used for prostate patient setup, and sometime if for adaptive radiotherapy, in-room CT was used for 3D prostate motion assessment. At the same center, we also had proton therapy, where an isocentric proton gantry was used for the treatment of prostate patients. This proton therapy facility has a robotic couch and in-room CT scanner and 2D flat panel. Here, retracted flat panel detectors are shown for 2D patient setup before treatment. All patients were set up using ankle and knee supports as well as head pad to get a reproducible prostate position. The objective of my thesis was to propose an effective clinical workflow for the prostate motion management during radiotherapy by analyzing the interfractional prostate motion under different setup conditions. The hypothesis of the study was that water-filled endorectal balloon-based setup reduces interfractional prostate motion. And assessing the bladder and rectal filling effect on the interfractional prostate motion, the hypothesis for this study was that the water-filled endorectal balloon reduces bladder and rectal filling effect on interfractional prostate motion. Third objective of this thesis was to make a dosimetric comparison of two planning target volume margin recipes by hypothesizing that composite prostate coverage concept leads to robust PTV margins. So, in the first study, patient cohort was selected with clinically localized or locally advanced prostate cancer, and there were three groups of patients, each comprising 12 patients. The photon therapy patients were treated without endorectal balloon as well as with the 80 milliliter air-filled endorectal balloon. And while at the proton therapy, water-filled 120 milliliter water-filled endorectal balloon was used. Exact X-ray image guidance was used at photon therapy, while in-room CT was used for image guidance at proton therapy. 415 and 446 and fractions were analyzed for patient groups without endorectal balloon and air-filled endorectal balloon, while 379 in-room CTs were analyzed for the proton therapy patients. Three gold fiducials were implanted in the prostate of patients at photon therapy, and to avoid the high atomic number inhomogeneities caused by high atomic number material, Ceramic seeds were used in the prostate of patients at proton therapy because proton beam is very much sensitive to high Z material that can lead to that can incredibly change the dose distribution in the prostate. Endorectal balloon for these were the two endorectal balloons. These were the two endorectal balloons for patient setup, an air-filled endorectal balloon and a water-filled endorectal balloon. Both balloons were having a graduated shaft and end stopper to get a reproducible insertion of the endorectal balloon to the level of comfort of the patient. Air-filled endorectal balloon was having smaller volume, while the volume filling of water-filled endorectal balloon was higher than the air-filled endorectal balloon. Both the diameter and filling length of air-filled endorectal balloon was also smaller than the water-filled endorectal balloon, from which it was hypothesized that the water-filled endorectal balloon will give smaller prostate motion. This is an overlay of the Exactrack X-ray radiograph and the digitally reconstructed radiograph from the planning CT, and the prostate motion was assessed by taking two views. One was used for the patient setup during treatment, another was obtained in offline technique by overlaying the two views using bony anatomy based shift. The actual patient setup was based on fiducial based shift, and the data was acquired during the treatment fractions, and bony anatomy based shift was calculated in a replay mode in an offline technique. Then prostate motion was assessed by subtracting the fiducial based shifts, bony anatomy based shift from the fiducial based shift. As we know that prostate is a soft tissue anatomy which can move relative to the bones. So if we subtract the fiducials from the bony anatomy shifts from the fiducial based shift, we get the pure prostate motion. In-room CTs, we have fiducials in the prostate of the patients, and this is also an overlay of the planning CT with the control CT in brown and blue planning CT in blue color, and the prostate motion was calculated by subtracting the center of gravity of fiducials in the planning CT from the center of gravity of fiducials in the control CT. Prostate motion was compared in along left, right, superior, inferior, anterior, posterior, and as well as the 3D motion vector. And it was found that there was no difference in the no endorectal balloon, air-filled endorectal balloon, and water-filled endorectal balloon groups along left, right, and superior, inferior direction. However, there was a significant difference in prostate motion between the no endorectal balloon and air-filled endorectal balloon patient groups along anterior posterior direction, as well as a significant difference in the prostate motion for no endorectal balloon and water-filled endorectal balloon for the 3D prostate motion vector. While the difference was lying at the borderline of significance for patient group with air-filled endorectal balloon and water-filled endorectal balloon, from which it can be concluded that 120 milliliter water-filled endorectal balloon reduces the interfractional prostate motion and fulfills the objective of this study. So we see that air-filled endorectal balloon has no significant difference in any of the case from the no endorectal balloon option. And while there is a difference between the patient group without endorectal balloon and with water-filled endorectal balloon along anterior, posterior, as well as 3D motion vector. In the second study, bladder and rectal filling effect on the prostate motion was assessed. For this proton therapy, the same 12 patients from the proton therapy where in-room CT image guidance was used, and 379 treatment fractions were analyzed, and 120 milliliter water-filled endorectal balloon was used for these patients, and ceramic fiducial, 3 ceramic fiducials were used. A single fiducial can't be used because a single and a double fiducial can give only translational motion assessment. In order to get rotational motion assessment, one need to have at least 3 fiducials. And a strict drinking protocol was used to get a reproducible bladder filling. It was an attempt, and we will see that it was there was still a large variation in bladder volume even after using a strict drinking protocol. This is the planning CT where where bladder, prostate, as well as rectal contours are shown. And these are the contoured control CTs from all the 32 fractions of the patient, of each patient. So we had a large intra-fractional, intra-patient variability option because we had control CTs for all the treatment fractions of this patient group. So here we can see this is this was incomplete bladder in the control CT because scanning length was not optimal. So it was technologist dependent. They used a little bit smaller scanning length. So such patient incomplete bladders were excluded from the bladder volume comparison. This is the superior inferior motion of bladder dome. This part of bladder is called bladder dome, and this is the bladder base. And we can see that the superior inferior motion of bladder base is much smaller than the superior inferior motion of the bladder dome. This is the anterior posterior motion of the interior rectal wall, and this was the gold fiducial at the tip of the endorectal balloon shaft, which was used for the superior inferior insertion level of the endorectal balloon. The rectal volume was taken around the prostate. Prostate plus minus 6 mm of the rectum was selected for rectal volume analysis because this region of rectum is not relevant, and due to scan length variation, this region is also not relevant. If we include the whole rectal volume, it can lead to this scan length variation confounding effect. So in order to eliminate this confounding factor, the rectal volume was considered only around the, because this is the rectal volume which can influence a prostate to greater extent. This part of rectum seemingly can't influence the prostate motion. This part of the region of rectum which is lying near the anus, this can also not influence the prostate. So this region is more relevant to assess the prostate motion driven by the rectal filling. And all motion and volume changes were calculated by subtracting the planning CT value from the control CTs. So the prostate motion for all acquired control CTs was assessed along left, right, superior, inferior, anterior, posterior direction, as well as the 3D motion vector. We can see the smallest motion was observed along left, right direction, and the largest was observed along the superior, inferior direction. And 3D prostate motion more than 5 mm was observed in 5.8% of the treatment fractions, while more than 10 mm prostate motion was assessed only in single fraction of all the treated fractions. So we can see the 3D motion vector of prostate motion was lying within a centimeter. So change in bladder and rectal volume was assessed, and we can see that this is the baseline where control city volume is equal to the planning city volume, and this part shows the where the volume of in control city is more than the planning city, and in this part lying below this baseline, the control city volume is less than planning city, and from the range of bladder filling variation and the range of rectal filling variation, uh, we can see that rectal fillings were variations were much smaller. They were more reproducible as compared to the bladder filling variations because of the use of rectal balloon. Organ motion and volume changes. So endorectal balloon insertion variations were correlated with the change in rectal volume. So the because it has different diameters at different portions of the endorectal balloon. So when the largest part of diameter was neighboring the prostate, at that time the volume of the rectum was largest, and when it is too far inserted or too less inserted, then the volume neighboring the prostate was changed due to the insertion variation of endorectal balloon. The change in rectal volume was found to be correlated with the anterior rectal wall motion, and anterior rectal wall AP motion was correlated with the prostate AP motion. So the anterior rectal wall movement in the AP direction was responsible for prostate AP motion. There was no, as we can see from the randomness of these scattered plots, that there was no change in bladder volume effect on prostate motion. So this was the main conclusion of this study. And we can see that when bladder volume changes, there is no effect at the base. It is not correlated with the bladder base motion. However, it is fairly good correlated with the dome SI motion. Actually, when bladder fills up, it moves upward instead of moving downward, thereby not affecting the prostate motion in superior, inferior, or any other direction. So for 120 milliliter water-filled endorectal balloon-based patient setup, even substantial changes in bladder volume didn't significantly affect the interfractional prostate motion, and the rectal volume is stabilized by using endorectal balloon. Further stabilization of rectal volume by a consistent daily endorectal balloon insertion can be achieved, because we found that endorectal balloon insertion variation lead to the rectal volume changes that are responsible for prostate motion. In the third study, a dosimetric comparison of two planning target volume recipes was done using the same 12 patient groups with in-room CT and 379 treatment fractions, and a 120 milliliter water-filled endorectal balloon with 3 fiducials and a strict drinking protocol. This is the prostate of a patient, prostate sagittal view of prostate of a patient in the planning city. And these are the prostates of the patients in the control cities. And the planning target volume margin was planning target volume was drawn by enveloping all these control city prostate. This is shown here in yellow by the 95%. If we cover the 95% of control city prostate contours by this yellow contour, we get a PTV margin around this is the composite prostate coverage PTV method, where 95% of the composite prostate is covered. So by combining all these control cities, we get a composite prostate, and then covering this composite prostate with 95% by expansion in all direction around the planning city, we get the composite prostate coverage based PTV margins. So these are the small areas where coverage is not complete, but we require 95% coverage of the as per the PTV margin calculation comparison with other methods. So we know that this is CTV and this is a PTV exaggerated in one dimension to correlate it with this distribution. If we say that PTV margins are normally distributed for a large patient group, then we can say that mean of the normal distribution will cover 50% of the patient population, and in order to cover 90% of patient population, this 90% patient population coverage was used to make this recipe comparable with the statistically determined PTV margin recipe from Van Herk. So one needs to expand. One need to go further the mean up to 1.28 standard deviations, thereby achieving the 90% patient population coverage. So Van Herk used the same strategy, but using statistical means to cover the CTV for 95% of the to give a 95% coverage of the CTV, including all the major uncertainties, and for the 90% patient population. So 95% coverage of the CTV, including major setup variations and interfractional prostate motion for the 90% patient population. This was the objective. Van Herk achieved the PTV margin by taking the standard deviation of the means of prostate motion. By taking the standard deviation of the means of the prostate motion, he obtained systematic uncertainty, and by taking the root means of the individual standard deviations of prostate motion, he obtained the random uncertainty, and then he combined both these uncertainties to get PTV margin by giving more than 95% weighting to the systematic uncertainty and 50% weighting to the random uncertainties. So this table shows the PTV margins for composite prostate coverage as well as Van Herk's formula based PTV margins. So we can see that composite prostate coverage lead to larger PTV margins as compared to the Van Herk's formula based PTV margins. In the clinic where I performed this study, they used 8 mm uniform PTV margins all around the patient, except they used 5 mm posterior margin because to spare the rectum. So the margins were adequate. Uniform margin strategy is an adequate approach because some uncertainties were not included in the study, like intrafractional prostate motion of the patient is not, as well as patient motion is not considered, and MLC leak positioning also have some uncertainty. If we include them, then we need to go beyond these margins. So volumetric modulated arc therapy plans were made and compared for both margin recipes. So these are the plans in the planning city. So close to the 98% of the CTV was 95%, and dose to the 2% of CTV was below 107%, which is the ICRU criteria for dose target coverage. And using the both composite prostate coverage and Van Hug's method, the bladder and rectal volume, dose volume constraints were met during the planning phase. And when these plans are recalculated on the control cities, the coverage for the composite method was not adequate for one of the control, but it was still higher than it was around 94%. So coverage was met for all. However, the coverage was not adequate for 12 treatment fractions in using the Van Hug's method. The dose constraint were met in composite prostate method for all patients, except in 37 cities where the coverage was where the volume at 70 gray was exceeding the 10% constraint, but it was not going beyond 15%. From this, it can be concluded that composite prostate coverage concept gives robust PTV margins by overcoming the limitations of Van Hug's by taking into account the prostate rotation, deformation, and as well as size changes, which fulfills the objective of this study. So in the end, to sum up, for 100 milliliter water-filled and rectal balloon-based patient setup, interfractional prostate motion used even
ज़िशान ज़का बोल रहा हूँ रेडिएशन कॉलेज से। अल्लाह का शुक्र अल्हम्दुलिल्लाह। यार ज़िशान ये पूछना था कि ये
even substantial changes in bladder volume do not significantly affect the interfractional prostate motion. So there is no need to purchase an expensive ultrasound equipment to check daily bladder filling before treatment. This was planned in our clinic to purchase an ultrasound equipment and daily verify the reproducibility of bladder filling. So after performing this study, they changed their mind for purchasing an expensive ultrasound equipment. Because bladder base doesn't move by bladder filling, it's only bladder dome that moves upward. Rectal volume is stabilized. Further stabilization of rectal volume can be obtained by consistency in daily and rectal balloon insertion. Composite prostate coverage method gives a robust PTV margins by overcoming the limitations of Van Hug's formula by taking into account prostate rotation, deformation, and size changes. These were all my colleagues who helped me in my PhD. I'm thankful to all of them, and thanks to all of the participants. If you have any questions, I would like to welcome.
Well, everybody can unmute their mic if they want to ask any question. There is one question in the chat box. Is there any significance difference between the two rectal balloon catheter which you have shown?
Yes, the volume, air is more compressible on the one hand, and the volume of air was 80 milliliter. Volume of air was 80 milliliter, while the filling for water-filled and rectal balloon was 120 milliliter. So there was a 50% increase in volume in case of water-filled and rectal balloon. Its filling length and diameter, they were also filling diameter was 1 cm more, and filling length was almost 3 cm more than the air-filled and rectal balloon. So in every aspect, it was bigger than the air-filled and rectal balloon catheters. Catheters, they are simply shaft, they are compatible like our couch material. So there was only a fiducial at the end of the shaft to assess the insertion.
Dr. Asrar, I have a question. This study is based on the treatment site. So if you see any changes during the treatment, so do you change in the planning or is just a study of visualizing the catheter on the patient setup?
Actually, proton therapy started in the late 2014 at Dresden, where I was working. So they want to analyze their patient setup. For that purpose, they assessed, they took daily control CTs and performed. I would say it's a large data for prostate patient to get a 3D image for each treatment fraction. But the purpose was to get to be assured that they are having a good patient and delivering that dose to the target instead of going not causing graphical missing or normal toxicity. So this data was acquired, and later on I assessed this data. So if there is anything that happened to the patient, I couldn't do anything. But it is good for the patient, new patients. That our clinical personnel, they were happy that they are having a good patient setup.
There is another question in the chat box. How much dose is affected due to the presence of air and water?
Yes, there is an effect of, we know there is a difference in the tissue homogeneity. I mean, air is quite different from the normal tissue. So if we put it into the rectum, an air-filled endorectal balloon, it can spare a bit rectum. It can spare the rectum a bit. But for proton therapy patient, we cannot afford putting air-filled endorectal balloon in the rectum because protons are very sensitive to inhomogeneity. So if air comes into the beam path, it can lead to overshoot. And if during planning there is air in the beam path, and during treatment, if there is tissue in the beam path, we will get an undershoot. So at proton therapy, we can't use air-filled endorectal balloon. We have the only option of using water-filled endorectal balloon. So due to scattering at photon therapy, there is some percentage of rectal sparing using air-filled endorectal balloon. Because as in the case of breast cancer, we see that sometimes people recommend use bolus to get dose distribution near the skin. So same thing happens for air-filled endorectal balloon that is put in the rectum. It leads to sparing of the rectum. I hope I have answered the question.
Okay, anyone have any other question? So we conclude our session. Thank you very much, Dr. Asrar, that you gave your precious time. And thank you all for the participating. Recording will be shared in our YouTube channel. In April, we don't have any webinar or academic session. Hopefully, we will do on May. And if anybody wants to be a speaker on academic art, you want to share his study or anything else, they can contact me directly on WhatsApp or on email. So thank you very much all.
I have a suggestion.
Yes, you can say.
If community likes, I can also deliver a lecture on proton therapy at this forum.
Yes, you can if you want to.
Yeah.
No problem.
Okay.
Just
No problem.
share the date and time when you want to do.
Yes, I'm ready. Maybe whenever you